So good afternoon, everyone. I'm going to be talking about how we can use case reports and information from medico-legal death investigations to design studies that will help us detect signals around the harms of NPIs and policies and other public health and social measures that were deployed during the pandemic. So we've had a little bit about case studies over the past day or so. Although traditionally they're seen as sort of the bottom of our traditional evidence pyramid, in terms of understanding harms and adverse events in the real world, they are often the best data that we have and are the backbone of many of our surveillance systems that are used in pharmacological research or medical device research. And these are sort of pulled together in these sort of national or international databases like the World Health Organization's VigiBase, or in the UK, our medical regulator runs what's called the Yellow Card Scheme. And so these databases are then used traditionally for epidemiological research or by regulators for what's called PASS studies, so post-authorization safety studies, or post-marketing, now called post-marketing requirements and commitments with the FDA. And these are used to monitor the safety of products in the real world. But when it comes to capture this sort of information from public health and social measures, we sort of experience many difficulties in trying to collate and track this information, particularly in the context of the global pandemic that we've all just experienced. So I could spend a whole sort of the next 15 minutes talking about mortality data during the pandemic. But if we take ourselves back to sort of early 2020, I would wake up every morning in the UK and sort of look at the latest dashboard of my local area and see where all the deaths were occurring. Many countries overnight started sharing this mortality data. However, we quickly came to realize that there were many sort of issues and concerns around the mortality statistics that were being shared. And I'll just share some of those for the context of my talk. So we found that these were often delayed and there's a sort of time lag. Most national statistics, particularly in the UK, when they are published, it's the date that that death was registered, not the date that that death actually occurred, which people don't often realize that with our national statistics. It's when the death was registered, not when the death occurred. We also, nationally and internationally, had a lack of these transparent data infrastructure to be able to share this information across the globe. And we came to learn a lot of different variations across countries and locally. So we had variations in diagnostic tests, access to testing, different types of tests, many different types of definitions. Carl did a big piece that found there was 14 different definitions on what was a COVID death just in the UK alone. So these variations could be whether the death had COVID at the time of death, within 28 days, or whether it was with COVID or from COVID, many different types of definitions of what meant a COVID death that existed. We also had variations in how these deaths were being coded, how these deaths were being reported, and how these deaths were being certified. And so I'm going to talk about the last one around the certification, the medico-legal certification of these deaths. So speaking sort of about just the England and Welsh context, so if we think, just showing an example of 1 year of data in 2023. So deaths that were registered in 2023 in England and Wales, there was about 500,000 deaths that occurred in that year that were registered. Then in England and Wales, a death will get referred to a coroner, and this will occur when the death is sudden, violent, unexpected, or the medical cause of death cannot be determined. Deaths also that occur in state custody, so deaths in prisons, deaths in immigration detention, deaths in workplaces, and deaths in mental health facilities automatically get referred to the coroner. And that happens in about 1/3 of all deaths, so about 200,000 deaths get referred to the coroner every year in England and Wales. We do have a new medical examiner system, and I'm not going to talk about that, but about 2/3 of all deaths will be reviewed by the medical examiner now, and this only just started in September of last year. So once that death investigation opens, the coroner will then start to speak to the GP, look at the medical records, start talking to expert witnesses, and decide whether an inquest needs to occur. So this will occur in about 6% of all cases in England and Wales. And then there's a unique part of the legislation where coroners have a duty to write what's called a Prevention of Future Death Report, or a PFD. Now, these are unique in England and Wales, but there are different in different systems across the world. So in Australia, for example, coroners can write what's called recommendations after an inquest as well. So this PFD system, a coroner will write one of these reports, and by law, they have to send it to an organization who they deem has the power to take action. That organization, by law, has 56 days to respond. And then the coroner will send their report and any responses they get to the Chief Coroner's Office in England and Wales. And that Chief Coroner will then publish that on a publicly available website. So this has been happening for 12 years now, and they're PDF documents that are sitting on a government website that no one's ever used or looked at. So my question as an EBMer, and I was commissioned for 1 year by the Judicial College in England and Wales to go and meet every coroner in the country. So there's over 700 coroners. I've now met every coroner. It's not a badge I wear, but, and I asked them, so after writing all these PFD reports, how many lives have you saved? And the whole room went silent. So I said, shout out, how many lives have you saved? Tell me about the deaths. Tell me about the lives that you've saved. How many deaths have been prevented from this national system that we have around, with the sort of, at the heart of it, is there to prevent deaths. And so 2 key bits of the puzzle were missing. One is no one in the country knew how many reports had been written, and no one knew if anyone had actually ever responded to a coroner's report. So that was sort of the rationale for why we needed something like what's now called the Preventable Deaths Tracker. And this was a project I created during my PhD at the University of Oxford. So now we can know in real time that in this year of 2023, only about 550 reports were written, which represents less than 0.1% of all deaths and about 1.5% of all inquests. And then in terms of response rates, despite there being this sort of legal requirement for organizations to respond, this sits at about 50% of all reports. But when I did start on this venture of the tracker, when I first published this data on who was responding, this sat at about 1/3 of all deaths. And after several audits and meeting every coroner in the country, we're now able to get that to over 50%. So that's sort of real-world impact for you in terms of how a tool can be used by frontline clinicians and practitioners to really get this number up to where it should be at 100%, but to really start increasing the number of responses from coroners. So during COVID, we looked at data, this was done in July of 2021, so some time ago now. But we wanted to use this information to try and look at how we could understand what deaths are being referred to the coroner where COVID had some sort of role in that death. And so we designed a consecutive case series of these coroner reports, and we used the Preventable Deaths Tracker database, which at the time was includes all published reports published in England and Wales. And this sort of time was we just looked at the 1st of January because it was easy to pull the data that way, until the end of June of 2021. So that was just 510 reports that we screened at that time. So this information, the way that the database worked at that time was I wrote a web scraper, which went onto the government website. It collected this information in a reproducible way that could be sort of replicated and repeated over time. And then those 510 cases were manually screened one by one to check whether the coroner mentioned COVID. We were interested in sort of 2 types of deaths. So we first wanted to see where the coroner had mentioned SARS-CoV-2 as a medical cause of death, which was one group. We called those directly related. And then we wanted to see where the coroner spoke about COVID or SARS-CoV-2 as a sort of indirect relatable part of. So either they died with COVID but not from COVID, or these public health measures like lockdowns and telehealth consultations was a contributory factor in the death as described by the coroner. So a very small number of cases that we found. This was very early on in terms of the pandemic, but only 23 deaths were identified, which represented just less than 5% of all these reports written in England and Wales between that time period. And we found a sort of equal split nearly, so sort of half were where they had SARS-CoV-2 as a medical cause of death, and the other half was where there was an indirect sort of relationship to the pandemic. but the sort of overall conclusion was that there was either that there was a lack of mitigation measures, so we saw a lot of sort of contamination in care homes and hospital-acquired SARS-CoV-2, or there was a lack of risk assessments, and so these sort of new policies, as we know, were being rolled out with any sort of risk assessment or ability to sort of safeguard potentially vulnerable populations. And so I planned to update this piece of work for this conference, but this has sort of been a project of mine that was a passion side hobby project that I was running on my weekends and evenings and driven by supervising medical students while in teaching roles at Oxford. And of June last year, I received a fellowship to move to King's College London, where I now am funded to work on this project. So in February of this year, I've now launched a new database that has gone live. And as part of that, so now the database still runs as a web scraper, but it's got lots of new features, including being a relational database that allows us to run free text searches. So this is the back end of the database that no one can see. But here's an example of typing in COVID. And now instead of the 23 cases, we have 71 hits that are coming up there. So when I ran a few more searches, we can see in a matter of seconds many new cases that have been published since June of 2021. But I'm holding that new data for you to come to Oxford in June of 2026, where I will publish and share those new findings from those 70 or so cases that have been published since June 2021. So I'm also a evidence-informed fellow, and one of sort of my missions of the fellowship was to expand beyond England and Wales. So this sort of medical legal death investigation data exists across the globe, but it's not being harnessed and used in a way that we can sort of use it for research and also create these live dashboard tools that can be shared and used for communication. So my first part of the fellowship was that I got to go home to Australia in February of 2025. And for Carl, I put up all my photos to prove that I actually went. No. But I had a fantastic time hosted at Bond with Paul and Mark and team. I also spent some time in my hometown of Queensland, where I got to go and meet the state coroner of Queensland, which was excellent. Spent some time in Sydney and Melbourne and we have in Australia a national database of coroner information. I got to meet the team that run that, so it was fantastic. So my next trip will hopefully get some more data on board, which I'll talk about in a moment. So one thing, instead of talking about Twitter, I'm going to talk about communication and working with the media. So about a year ago, I was approached by a journalist at the Times, Sean, who had personally had some bereavement. He lost his daughter at 28, and he wanted to use the database to look at a totally different project. And so we started sort of forming this working relationship where he'd said, Georgia, do you have data on this? And I'd say, do a quick search. Yes, here you go. We'd write stories about it. And then we sat down for coffee one day, and he said, Georgia, we need to tell the world about your story, that it has taken an Australian to come to the UK and build the only data infrastructure for the coroner system. And so I wasn't too happy when I saw one woman. I thought it could have been like scientists. But the first or second week of January, about a series of sort of 5 to 6 articles were published in the Times about, we did a story on some deaths that had occurred, as well as the fact that it's literally taking someone on their PhD and weekends to be sort of driving forward this database. So this article went on the top stories. It was what number was it? Number 3. Number 3 top stories for that day. It was then on the home page of the Times, which was huge. And then it was also in print. So I was very excited to see that go live. In addition, so once that went live that week, I got a lot of emails. And one email that had the subject of the email saying funding. And I thought, oh, here we go. But after responding to that email and many conversations later, I've now received philanthropic funding to build the tracker for Scotland. So by next year, we should also be including data from Scotland. So my summary and take-home messages are that information from coroners can provide insights on the harms of NPIs and policies, which can be used to create surveillance systems and to design studies where we can actually start looking at some more contextual information that will give us signals to look at harms from these policies and other interventions. The Preventable Deaths Tracker provides a reproducible method that can automatically collect this information. We standardize narrative information and provide real-time analytics that's being used by over 200,000 people across a wide range of backgrounds, from coroners to lawyers, healthcare professionals, bereaved people, the media researchers, and policymakers. And this sort of has allowed these tools to get built that can be used for public communication of evidence, including dashboards and newsletters that enable impact beyond academic publications. I know that 200,000 people have not read my academic publications. And finally, it's quite difficult to get funding for these sort of things. So there's sort of this consistent problem around sustainability. So finding funding and also who is actually responsible for running this type of data infrastructure and these surveillance tools. So this is a major challenge that it's not sort of seen as traditional academic research, and so it's also not prioritized by governments. I will leave it there, and I'm happy to answer questions later on.